2, 1. We are live now.
Uh, good evening, everybody. Welcome again to this webinar brought to you by the Orthopedic Research and Education Foundation India through Ortho TV. Today we have the pleasure of having Dr. Vikas Agashe from Hinduja Hospital, Mumbai. And he's going to sort of continue on his earlier talk on osteomyelitis and how to manage various situations. So I believe he wants to make it a little interactive. So that is great. So over to you, Vikas.
Thank you very much, John and Janki.
Vikas?
Can you hear me now?
Hello?
Can you hear me? Yeah. Okay. Thanks a lot. I would be discussing more about dilemmas in osteomyelitis, essentially hematogenous osteomyelitis. Last time we had discussed about prevention of infection in open fractures as well as management of post-osteosynthesis infection. Now today I would focus more on osteomyelitis. All of us have been managing osteomyelitis. I mean, it's so common a disease. And therefore, everybody has an opinion. And obviously, there are going to be different opinions. So respecting differences is friendship. So what I would do is, at least some cases, I will open up for discussion. So I'll start with a case which is generally called how I could have treated this case differently. So this was a young man presented with severe pain in the left thigh for 3 weeks, history of fever for 2 to 3 weeks. And when he came in, there was a distinct swelling in the thigh, visible swelling in the thigh. You can see both the sides. Then there was a small sticking plaster on the biopsy scar. He had a flexion deformity of the knee. Movements were painful and his ESR CRP were raised. So obviously, we are possibly dealing with infection. When I went through the history, I realized that his X-ray was reported as query periosteal reaction, suggestive of tumor or infection. And hence MRI was done and it was reported as highly suspicious for malignant neoplasm. So he was referred to our oncosurgeon who did a needle biopsy and it grew methicillin sensitive Staphylococcus aureus. Histopathology was also suggestive of osteomyelitis. So the radiologist reviewed MRI and then said, no, what you say is right. This is an osteomyelitic process in distal femur with signal abnormality reaching up to condyles. And there was a soft tissue abscess. So obviously, we have a tissue diagnosis now. And everybody felt that this was an acute osteomyelitis because it fits into definition, a recent bone infection that causes systemic inflammation, as against chronic osteomyelitis, where generally a sequestrum or involucrum needs to be present as a result of infective process. So what should I do? Should I treat with only antibiotics as per the culture? Because we have now a tissue diagnosis with culture specific antibiotics can be started or explore immediately, make a window to drain pus. Now it's almost 30-40 years since Nade presented his principles. Antibiotics are effective before pus forms. They cannot sterilize avascular tissues. They prevent pus formation once pus is removed, but not when there is pus. They will not be very useful. Pus removal restores periosteum and restores blood supply, and antibiotics should be continued after surgery. These were his principles, which he proposed way back in 1978. And obviously, I decided that I must follow Nade's principles. So I decided to explore. You can see there is that's the incision I took, excised the biopsy scar. There was a granulation tissue covering the lateral aspect of femur, and moment I made a drill hole, the pus actively came out. like a fountain of pus there. So I made a window connecting multiple drill holes and drained the pus and scraped the granulation tissue. I also made a separate incision. Here you can see for partial synovectomy, drained pus from the joint, did a partial synovectomy. Also made multiple drill holes here at the lower end femur, as you can see here and here, made a small window to let out pus. Our ID consultant started cephalosporins and later on put on oral cephalosporins. We also inserted cefuroxime. So with stimulant, as you can see here. So now is a dilemma or question to all of you. Are you happy with my surgical treatment? Are you or are you not happy? Can we have a show of hands? I'll stop sharing now.
Yes. So I think all of you can make
I'll
yourself
stop
online.
sharing.
Yes, sir.
Yeah. So who would say that I have done a great job? Who would say, no, I should have just made small drill holes? And who would say that I should have made a big window?
I think Sachin and Pushpinder is here. You can comment here. Sachin, you can say has given the option A. He has written.
Okay.
Yeah.
So A is yes, happy. Okay. Then Alok Sinha there.
Yeah.
Anuj, Alok Sinha. They all can see the presentation and of course.
Yes. Alok. Yeah, he has also written, but the same. Yeah.
Same A. Okay. So let's proceed.
Yes.
So 2 out of 2.
Yeah. So
yeah.
One more.
Yeah, but I would say it would you'd have to look at things at the time of surgery, and usually when you have such a wide area of infection, it's difficult to clear it out through one small window. You probably need to extend it further to be able to get everything out.
Yes, sir. We have got one more comment about that. That bigger window with cement beads antibiotic insertion.
Go all the
okay. Yeah. Anyone for stabilization?
That's another option that you need to decide on once you've done your debridement.
Correct.
Yeah.
Correct. So let's proceed. As I said, this is a case classically termed as what I could have done differently.
Okay.
So at 2 weeks, very comfortable. His fever and pain settled immediately. CRP returned to normal in 3 months. ESR declined. And this is at 5 months, very comfortable, no discharge, excellent wound, and everybody was happy. Now, this is a very, very important thing. If you want to spoil your good results, have a good follow-up. So at 6 months or 5 months, he lifted heavy weight and turned. He turned and heard a noise and developed very severe pain. And he could not stand or move. And this is what we had. He has a fracture. He has no fever, no local warmth, minimal swelling. His ESR CRP are normal. Now, what could be the cause? Too big a window, could have just made small drill holes. Too small a window, could not have drained the pus adequately. The angle of window could have acted as a stress riser, or this should have been stabilized with a nail. I will go ahead with the next thing and then we will discuss. Now what should you do? How many for close reduction and nailing? Can we have responses on the chat box? How many for close reduction and nailing? How many for open reduction and plating or nailing? How many for MIPO, external fixator, antibiotic nail, or will not decide without doing an MRI?
Yeah, we are waiting for the answers.
Yes.
Yeah. So B, I have got open reduction and plating,
Plating.
one, and another one is antibiotic nail followed by
Formal nail.
Formal nailing. Yeah. Then again
Then
B.
B,
So
open reduction and plating.
yeah, no one is for close reduction and nailing. So,
Okay. So as Dr. John said, that possibly the debridement was not adequate. So there is no point, especially when you're dealing with a pathological fracture, in a case where osteomyelitis has been scraped, you must find out whether the disease is still there or not. So you should not decide without doing an MRI. So first step is an MRI. So now you can see that they're suggestive of osteomyelitis. There's large soft tissue, large collection, and MRI findings are highly suggestive of proper osteomyelitis and not just reactionary changes, because there is a large soft tissue collection. So that is the osteomyelitis.
Vikas?
Yeah.
He's had a pathological fracture. How easy or difficult is it to interpret the MRI at this stage?
Yes. Generally, blood will have a different signal intensity. So they were very, very sure that this is infection.
Okay.
Because of the pus. They felt that this is definitely a purulent collection and not blood. So what should I do now? Obviously, I have recurrence is actually not recurrence. I would say it is inadequate exploration, inadequate debridement. I have a pathological fracture. I have an osteomyelitic process from middle third to lower third. And most important is, this is type 1 complication. Type 1 complication is operated by me. Type 2 is somebody else has operated. So this is operated by me. Now what should I do? First and foremost, A, I have to eliminate osteomyelitic process, and B, I have to aim for fracture healing. So both these issues need to be addressed. If I have to eliminate osteomyelitic process, I have to be very, very aggressive as regards debridement is concerned. And of course, antibiotics, local antibiotics, everything needs to be checked, and excellent monitoring, which was probably not there. Maybe at 4 months I could have done an MRI. But what happens is, up to first 4 months, generally the reactionary changes in MRI confuse you.
So there is one question, sir.
Yes, please.
Is that if we are sure to open and see it, then why to go for MRI scan?
Perfect. Number one, we must assess the osteomyelitic process. We must assess the extent of osteomyelitis, cortical involvement. I will explain it with the next case, what I mean by cortical involvement, and why MRI as well as CT become very important in these cases. So I'll answer it when I am discussing the next case.
Okay, sir.
So what should I do? If I have challenges, would be I have previous window, I have sclerotic edges of that window. So if I do an external fixator or ring fixator or antibiotic nail or a plate, these would be my options. And of course, since there is a window, bone grafting would be almost mandatory. So what are the options? Either make a large window, then I can do a thorough debridement like Dr. John suggested last time. But there is a change now because I have a pathological fracture. So this large structural defect in a fracture scenario would be very, very challenging. The other option would be either scrape or ream through the fracture site, because I have already opened the fracture and I don't create additional structural defect, but my debridement may not be as good as making a window. Now, if I stabilize with external fixator, possibly there would be less chance of recurrence, but chances of delayed and non-union would be high. If I use an antibiotic nail, possibly, and this was done about 8 years ago. So I was little concerned about using an antibiotic nail. Today I may not be. And less chances of delayed or non-union. So I decided to scrape through the fracture site. I used LRS or reconstruction system. And whenever one is using an external fixator till fracture healing, then it is worthwhile, especially with this window, make a non-anatomical but stable reduction. Make a non-anatomical but stable reduction like this. And then I put antibiotic beads. Yes, please.
Sir, there may be one more option for musculae for this case.
Yes, correct. Absolutely right. But as I said, this was almost 10 years ago, 8, 9, 10 years ago. That time, I thought this would be worthwhile. Agreed. Absolutely. So at 6 weeks, I removed, but by then you can see the bone has already started uniting. So this is at 8 months. This is at 30 months. But if you see, I lost some range of movement. He lost some range of movement. Because you use an external fixator for a long time, very often there's quadriceps adhesions. And that often leads to this restricted range of movement. So I learned several lessons from this case. Number one, the corner acted as a stress riser. Number two, window did not perform its function. So adequate and thorough debridement is vital. Cortical window deserves more attention as regards location, size, and shape. The pathological fracture, possibly because I made a very small window, the edges were irregular, there was inadequate access to medulla, and the debridement was inadequate. So here I should have made a large window. Now the next question would be, if this is an acute osteomyelitis, why should we do that? In children, we often make a very small window and that's it. So why should we make a large window, especially in case of acute osteomyelitis? Now this is something worth reading, a fantastic paper, I think somewhere in 2019, Evolving Concepts in Bone Infection, Redefining Biofilm, Acute versus Chronic Osteomyelitis, the Immune Proteome and Local Antibiotic Therapy. A fantastic paper, and what they say is, though we say that acute osteomyelitis is bone infection that causes systemic inflammation and chronic osteomyelitis is of longer duration and treatment changes, what they say that it is very difficult to say when acute osteomyelitis ends and goes into chronic osteomyelitis. So there is a lack of scientific rationale for selection of a specific time point causing this, whether it is acute or chronic. There is extreme patient-to-patient variability, and most important, pathophysiological variability at cellular level. And therefore, here you can see that's a picture from the paper, that in the same lesion, there can be areas of acute osteomyelitis and chronic osteomyelitis. And therefore, they say that this classification is meaningless. This classification is meaningless. Think why bacteria persist. And one of the most important thing, even in hematogenous osteomyelitis, is biofilm. We used to think that biofilms exist only in implant-related infections. So no, even in hematogenous osteomyelitis, biofilm forms, and that is the reason why the bacteria would persist. There are several other mechanisms, but most important is biofilm. So like last time we had also discussed, initially they are in planktonic form and can get killed by antibiotics. But After some time, if they remain for some time, especially in body's defense mechanisms are not appropriate, then they start getting embedded into extracellular matrix, which they secrete themselves, as you see here. And then the metabolic rate decreases, inflammatory signs decrease, your ESR CRP may be normal, and slowly they start forming pus. So remember, pus is a byproduct or product of this, which is just a thick yellowish liquid produced by infective tissue consisting of dead white cells and bacteria, but that is not the source of infection. So if we make a small window like this, we'll be able to drain pus, but the culprit remains. This culprit remains, and the pathological process would go on. The ESR CRP may remain normal, but the problem continues. So unless you make a generous window to remove this biofilm, your real problem or real enemy would persist. Once you scrape, then most of the bacteria you have removed, and whatever are remaining will be in planktonic form, and they can be addressed by antibiotics. So step one is make an adequate window to do thorough debridement. Problem is how to make it safe. Everybody is concerned that there would be a pathological fracture. I made a small window, still he had a pathological fracture. But I made a small window, and that was the cause of pathological fracture. So how do you make the window safe? First and foremost, go through the thinned cortex. Preferably include the cloaca. The edges should be regular. Shape should be elliptical and not rectangular. We are so much used to making window rectangular that those angles are likely to cause or work as a stress riser. So ends have to be smooth and circular. Then chances of this window leading to a fracture are much less. So I should have made this complete incision, and my window should have been like this. So conclusion, size of window determines completeness of surgical procedure. Shape of the window determines possibility of fracture. Pathological fracture can be result of both incomplete procedure and stress riser. And lastly, external fixator may lead to malunion or non-union, and that is why more and more people have started opting for especially for a long bone osteomyelitis, for a nail and a musculate. So now, are there any questions? I'll stop sharing.
Yes, sir. So one thing what you have mentioned, sir, is about the bone graft. So for this case, sir, you have done bone grafting also when you are doing second time?
Yes, I did bone grafting also. I took out the antibiotic cement beads and put bone grafts. Since there was a window with sclerotic edges, I had to take out those sclerotic edges.
No, but you did it at the stage after taking out the beads.
After taking.
Yeah, you didn't do it
at the time of external fixator, I took out those sclerotic edges, sclerotic infected edges. So that created a defect. So that defect, whatever you do, would need bone grafts. So that's why I planned for a bone graft after I took out the beads.
Yeah, so that's different. So
yes,
the infection is.
So unless you are quite happy with the infection control, there is no point in doing a graft. But if you had noticed, even at 6 weeks, in presence of those beads, there was decent periosteal reaction and new bone formation. The whole thing became quite stable.
There is one question from Dr. Alok. What is the site of window? Anterolateral cortex or lateral?
Yes, I will explain it with the next case.
So, do we can make the window where the sinus is present, or if that is in the area where the vascularity is, we can make it on other side also? Is it possible, sir? Or
so as I said, let's discuss it with the next case.
Okay, sir. Yes, sir. So if any other question you have, please ask. Sir, right now we do not have questions.
Okay, we'll go ahead. So I'll straight away go to this case. Just one important thing. Remember this, especially while giving antibiotics. Aim for getting culture. There's several things that can be done, but the reason is once upon a time, as I said, microbes were obedient. Today they defy us. They control us. So you must know the bug and culture. Okay, so a similar patient had pain and swelling of the thigh, same location. That's why I've chosen this case. And you can see that's the axial section, that's the medial cortex. There is a collection on the medial and posterior cortex, right? So will you start antibiotics empirically? No, we have already discussed that. Would you do an image guided biopsy or explore? No, we have already discussed that. So this patient was started on antibiotics, but he did not settle, and therefore he went to another surgeon who decided for surgery. Now is a question. I go back, that's the posterior medial cortex that is perforated. And would you like to do a lateral approach or a medial approach, swashbuckler approach, or any other? Where will you make a window? Lateral, medial, or scrape through cloaca? I will proceed now. And what would be the size of window? That we have already discussed. How will you collect the sample? Again, that is what we have to decide. So the second surgeon operated by taking a medial incision, treated with appropriate antibiotics after it grew MRSA, but his fever and pain persisted, and that is the time when he approached us at about 6 weeks. So this is where I am. The disease process has progressed. Now you can see there is a large collection on the medial side and posterior side. That's the osteomyelitic process, and these are the cloacas, and that's the window he has made. So what will you do? Obviously he is not settling, so I have decided to explore. Correct? When will you explore? Since he is diabetic, since he is very uncomfortable, there is no point in doing anything. Now what do I do? Now let's have a show of hands or on chat box. A, medial incision. B, medial incision but extend the incision. Medial incision, excising the incision. Lateral incision, bilateral, or any other. So now I would request people to comment, to answer what would they like to do.
So you write your
A,
answer
B,
in
C,
the
D,
chat
E,
box, sir.
F.
I'm waiting, sir, for the response.
No response.
Not yet, sir.
Let's start with A, Ameya.
Yeah.
Let's start with Ameya.
Yeah, sir.
2 responses.
Yeah.
Anuj, B.
B. Sachin, medial in different way.
Medial in different way. Can you just explain, Sachin?
Yeah, Sachin.
Can he unmute? Can he unmute?
Yes, sir.
Okay. Sachin, what do you mean by medial in a different way?
Yes, sir. Hello.
Yeah.
Will you speak loudly? I can't hear you.
Yes, sir. Am I audible, sir?
Yeah, now you are.
Sir, sir, we proceed approximately little more lateral, and as we approach to the infective side medially.
Anu, you are really not audible. I can't
Hello,
hear
sir.
you. I
Yes,
can't
Sachin.
hear you.
Sir, we approach through Stratford medially, but
Yes.
at the distally when we approach, then go through a little bit lateral, so that the
Okay, so you will possibly start medially and then proceed further anteriorly and laterally, right?
yes, yes,
Okay. Okay. So this is where you will have to decide where will you make the window, correct? Approach through the same window or extend the existing window, or will make a separate lateral window.
sir, extend the exiting windows, sir.
Extend the window. Okay. Any other opinion? Any other opinion? No other opinion? Will you stabilize or
No.
will not stabilize?
Yes, Sachin.
Sorry.
Will you stabilize or will
Stabilize.
not stabilize? There is
Yes.
one response.
Stabilize, sir.
Stabilize. Acha, Amay had just joined. Okay, no problem. You will stabilize. Okay. With a nail, antibiotic nail, external fixator, Elizaro, any other. So I'll proceed. I have to have a good access for clearing infected tissues without unduly weakening the bone. I mean, that's the most important. I should not weaken the bone too much. My incision should allow excellent access to make a window and possible sites of infected tissues. And here you can see that this is a localized this thing. That means cortex and medullary involvement, but at least part of the bone at that level is uninvolved at the same axial level. So axial stability is not compromised. In most of our non-union cases, axial stability is compromised because at a particular level, there is lack of cortex all around. So this is, though the host has systemic compromise, locally there is axial stability all along. So this is what you have to think, where all infected material is going to be. Previous incisions, drain site, sinuses if any, if the scars are adherent, soft tissue abscesses which may or may not be in continuity, and they would be tracking along the anatomical structures. So that happens very often. Bony along the medullary canal, cloaca, and this is something which is often forgotten. Intracortical abscesses, either opening superficially or into deep. And that is often a cause of recurrence. So here you can see these are the intracortical abscesses. So unless you specifically look for those abscesses, you are likely to miss them because they are generally covered by periosteum. Now one has to identify the previous incision and most important the drain. Very often the drain also will have a focus of infection. So the incision, now here we repeated the MRI. You can see the process has increased significantly. There is a large abscess on medial side. The CT shows these abscesses very well. And there is a cloaca on the medial side. Now, very often we are used to making a window on the lateral side of femur because it is safer. In this case, when the cortex is already compromised on medial side, you make a window on the lateral side, there is very likely to be an axial instability. So you must, as Sachin said, you must extend the window, the previously made window. And these multiple intracortical abscesses have to be addressed. So best to extend the medial defect and get an excellent access. Making a lateral window will cause axial instability. So best to make a medial window. Naturally, you have to have a medial incision. Now, are the femoral vessels going to be at risk? So it is better that, all these things, it's best that you go to a radiologist, to your radiologist or MRI consultant, sit with him and know where are the vessels. They are far away, so there is no problem. So I excised the incision as well as the drain side. Here you can see that's the soft tissue which is almost encapsulated, and that's the previous window and cloaca. That's a window, that's a small cloaca, and here you can see the window made with round edges, elliptical window with round edges, and through which we could scrape everything. That's the size of window, almost 10 centimeters or so, more than that. And this is what I've been talking again and again. You can see, unless you open the periosteum, you will miss these. So keep checking where are these intracortical abscesses. The inner one you would be able to scrape through your window, but these outer ones, these you need to explore from outside and scrape them. So this is finally the window, that's the gel foam that I have put in. This the size of window, which is almost 12 or 13 centimeters. That's Vanco granules we have put in on 4th day. And this is at 8 weeks. I like to keep a chart like this, ask patient to keep a chart of pain as well as the blood markers, so that at one glance you know whether the patient is improving or not. And this is at 3 months. This is at 9 months, absolutely comfortable. It's almost 1.5 years now and is very, very comfortable. So no surprises now. So that is why, again, I would say that making a small window defeats the purpose of window. Make a decent window through already weakened cortex and look for those small intracortical abscesses. Any questions now?
So
Any questions?
there's just one comment is the use of you talked about scraping. What about the use of high-speed burrs?
Yeah,
They
so
are
what
very
I
useful,
generally do,
especially in rounding.
yeah, I
of
forgot
the
to
edges,
mention.
as well
I forgot
as
to mention. Yeah. So initially I make a window with small drill holes, scrape it properly, and then once I'm reasonably happy, then I use high-speed burrs to make that smooth. But generally I don't start with high-speed burr because you need to pour in lot of saline. But then once I'm done with the window and scrape, then I use a high-speed burr.
So,
yeah.
Sir, is that 1 or 2 antibiotic you use if it is on the basis of culture and sensitivity?
Yes.
If like it is sensitive to 3 or more antibiotics, then it is just 1 antibiotics enough or 2 antibiotics we can use?
There's little difference between the antibiotics for osteomyelitis where you already scrape and a case where implant is retained. If the implant is retained, then one would definitely need rifampicin or ciprofloxacin in addition to other antibiotics, because they are the ones which go through the biofilm or biofilm active antibiotics. Number two, when you are using colistin, then you need another antibiotic because only colistin develops resistance very fast. But otherwise, most of the times just one antibiotic is adequate.
So there are a few questions, sir.
Yes, please.
One from Dr. Amay. If the defect is large, then what is the, sorry, sir. Yeah,
What is the?
just a minute. Yeah. What is the cut
Yes.
for bone graft or fibular graft?
Correct, correct. So generally it is said, I take you back to 1998, a fantastic paper by Sarni and Kevin Texworth on scraping of osteomyelitis. And they said that up to about 20 to 25% of circumference can be used for a window. If you have 75% circumference which is intact, then there is no need for stabilization. Now, that means every time you need to do a CT, that is what they did, which is really not possible in our country. But if you make windows like I have made, then generally it is not necessary to stabilize it or bone graft. If there is a large window in transverse or axial section also, then it is better to put stabilize it and put a graft. I would not suggest grafting without stabilization. If the case needs bone grafting, then it is worthwhile doing some stabilization also. What would you say, John?
Yeah, absolutely. I mean, you have to make a decision at the time of your debridement, and you don't always have to stabilize, but there will be certain situations where if you're worried about a pathological fracture, you need to stabilize. Now, what do you use for stabilization is a choice that you have to make, because I mean, in our setup, we very often go for plates, but using a locking plate as an internal fixator rather than using an external fixator. So we use a locking plate off the bone with multiple locking screws only, and sometimes use antibiotic cement with it. And that seems to work quite well. There's, I think there's some evidence now in the literature. When we started it, there was absolutely nothing in the literature about using plates in these infected situations. But now there are people who are doing it.
How often would you do a supracutaneous plate as a fixator?
That means outside skin?
Outside the skin, outside the skin. I mean,
I somehow don't think it's a, I mean, we can use it. We've done it once or twice, but more in the tibia than in the femur, because femur, it ends up a very long way away from the bone.
Right.
And you lose stability. It was.
So, role of sinogram. So about 20 years ago, sinograms were extremely common. I mean, most of the chronic osteomyelitis, we would do a sinogram. Now, with the MRI and the quality of MRI that we have, the role of sinogram has decreased. However, if you feel that you are going very near the vessel, then sinogram as well as methylene blue injection on previous night is useful. But otherwise, with the MRI, you can easily trace the sinus tract, and sinogram may not be useful. What is your opinion? How often do you use sinogram, John?
About the sinogram, sir.
Okay, so what we do is in some patients where they have chronic infections with little sinuses, so sometimes we want to know where these sinuses are leading. We don't do it routinely, but we do them, and sometimes we combine them with ultrasound rather than doing an MRI. It's a combination of a sinogram and an ultrasound to track the sinuses. They work pretty well as well. But yeah, I think if you have a person who can interpret the MRI adequately, that's probably the best way
Correct.
to do it.
So use of sinogram has gone down significantly. When
I
Dr.
think
John
sinogram
and
is
me
good
started
because you can
practicing-
interpret it easier.
Sorry?
Advantage of sinogram is you can see what is happening.
Right.
MRI, sometimes you are just dependent on the radiologist more than anything
Correct.
else.
So when we started practicing, I think almost every chronic osteomyelitis, we would do a sinusogram.
True.
Not anymore.
So there is one more question, sir. Duration of antibiotic after debridement in acute versus chronic.
Whether it is acute or chronic, generally for 6 weeks. Generally.
And yes, sir, you have mentioned about rifampicin also, sir. So
Yes. Okay. So rifampicin works quite well for gram-positive infections, which form biofilm. So most of the gram-positive infections are Staph aureus or cons or coagulase negative staphylococci. Rifampicin per se should not be used. It is used, as I said, only when you retain the implant, number one. Number two, when you have done adequate debridement and not just a small swab culture. So the microbial load has to come down, then only you start rifampicin. So that's about 12th day or 14th day when the load has gone down, using other antibiotic, and should never be given alone. Should be generally given for about 6 to 8 weeks in a higher dose. So the dose is 300 to 450 milligrams twice a day, and not like TB doses.
Okay.
So I'll
increase the
quickly
dosage for when you do it.
Sorry.
So increase the dosage when you use it for osteomyelitis. So
Yes.
That's interesting.
Yes. But in standard osteomyelitis, there is no point in using
You
rifampicin.
won't use it.
It is
No.
only in implant-related infections with retention of implants. If you are taking out implant, there is no point in using rifampicin. So there is one more question as I see.
what antibiotic to be given if the culture report is resistant to all?
So generally, as of now, most of the things work, the colistin works, or now there are so many newer antibiotics like fosfomycin, and most of the patients are not resistant to fosfomycin. A funny thing about colistin is colistin and meropenem, even though they are resistant to meropenem or resistant to colistin, they are known to work, because our ID specialist explained it in a very nice way. He said that even though they are resistant, the colistin breaks open the cell covering or cell wall or whatever covering is there, and then meropenem acts. So they work as a team and would work in these cases. So there have been papers where the culture is resistant to everything, including colistin. Still, colistin and meropenem combination works. And as I said, now there is astrozonome and so many things which are actually, I mean, I will not be able to tell you which antibiotic to be used, especially in these cases. But there are these combinations that can be used.
Okay. Any more questions? Otherwise,
No, sir. No, not any more
okay,
questions,
then
sir.
in that case, Vikas, you have anything further to say? Otherwise, we need to close up.
Quickly, I'll run through something about sample collection.
Okay,
Containers and
did
sample
that
collection.
last time, didn't you?
I don't think so. I don't know.
Okay.
Janki, did we discuss that?
Yeah, I think we
No,
discussed it last time.
Acha, we have,
How you take cultures, etc. Yeah.
okay.
But you
in
can
the
go through
discussion.
it quickly. Yeah.
So most important is maximize culture yield and minimize no growth.
Yeah, we went through all this, I think.
We went through all that. Okay, fine. Then I'll stop share.
So,
So if there are no more questions, shall we wind up?
yeah.
Okay, great. Thanks very much, Vikas. That
Thank
was
you very
really
much.
very
Thank you. Bye-bye.
Thank you so much, sir.
Bye. Bye,
Yeah.
everybody.
Yeah, I think so now. Thanks very much. That was great and very informative. And Thanks for doing it on a week where you had to deal with Diwali and many other functions, I guess. So thank you very much, Vikas.
Okay. Bye. Bye. My pleasure.
Thank
you.
My pleasure.
Thank you.
Hope to see you
Okay.
in Delhi
Bye.
anyway.
Bye.
Thank
See
you so
there.
much, sir.
Bye, Janki. Bye, everybody.
Thank you, sir.
Bye. Bye.